Good morning, everyone. So I am Isha Chitroda from MD4, and today I'm going to be presenting my RNSORP2. So this is the case that we have today. A 45-year-old male who's a recent immigrant from Indonesia presents with unintentional weight loss, malaise, and productive cough with yellowish sputum. And he has diarrhea. Sorry, he does not have any diarrhea or vomiting, but he does have fever, and he shows a cavitary lesion in the upper left lobe of his lung. So, I think I can conclude from the case that this is a case of secondary tuberculosis, and the differential diagnosis that I think of is that it could be either lung tumors or occupational diseases. So, for lung tumors, since there was mentioning of cavitation, I think that I can relate this to squamous cell carcinoma, and the lesion can be coin-shaped, so I was also thinking of somewhere along the lines of a hematoma. And then since it is a upper lobe lesion, it could also be various types of occupational diseases such as scoliosis or silicosis. So these are the Burns factors, and I think that we all agree that the bacteria that causes tuberculosis, Mycobacterium tuberculosis, and the virulence factors here are mycolic acid, that basically is the reason of acid fastness and gives resistance to the Gram staining. Then you have the core factor, um, which is basically responsible. It is actually a surface glycolipid that produces serpentine-like growth factor, and it inhibits neutrophil migration, and it produces tumor necrosis factor alpha. Sulfatidides, they inhibit phagosome-lysosome fusion. Lipoarabinomannan is also a surface glycan that produces interleukin 12 and tumor necrosis factor alpha. And then you have catalase peroxidase enzyme. This enzyme basically inhibits the killing by the reactive oxygen species. Now, the pathogenesis or how this occurs. So you have the PAMPS or pathogen-associated molecular patterns that are recognized in this case, mannose and etc. So they release cytokines. Basically, they get phagocytized and they release cytokines like interleukin 1, interleukin 12, interferon gamma. And what happens is that they replicate in these phagocytes, and they can spread either by the lymph nodes or either in the blood. So this is a type 1 type of immune response, and this releases interferon gamma, which stimulates production of macrophages, and it helps in killing of the bacteria by autophagy and by phagosome formation. And macrophages produce tumor necrosis factor, which helps in the granulation, and granulation is really important to help decrease the spread of diseases. Granulation occurs, there's epithelioid cells, giant multinucleated giant cells, and it basically helps to not spread this infection. But what can happen is there can be destruction of macrophages or killing of these macrophages by these bacteria, and it can lead to caseous necrosis of the lung, which can create cavitation and also further tissue damage. So the risk factors are immunocompromised patients, basically people who have diabetes mellitus, or they can be AIDS patient or HIV patients, or they can be previous TB infected people. So people who have had primary tuberculosis before, or they've been infected, but the bacteria had been lying dormant until now. Then you have two types of staining technique. As we already discussed earlier, that this bacteria is acid-fast. So we'll be using acid-fast stain or Zell-Nelson stain, and it gives the bacillus a pinkish like color. And the other one is fluorescent or ormuramine stain, which gives this bacteria as a reddish yellow or also a green type of color. The test here we use is Montaut tests, which basically is a type 4 hypersensitivity test, which measures the type of CD4 T cells. And how you can determine is that they measure the size of the reaction, and that can determine the stage of the infection and the positivity or the negativity. Then you have the interferon gamma release assay, which basically measures the interferon gamma produced by the Th1 cells. And then you have the nucleic acid amplification test, which it simulates, formation of RNA and DNA of the bacteria, and it gives rapid results and it's faster. So now you have the treatment. So you have isoniazid, which inhibits glycolic acid, and it can lead to hepatotoxicity, and it can also lead to sideroblastic anemia because it inhibits B6. Then ethambutol blocks arabinosyl transferase, which is also part of the cell wall, and it can lead to optic neuritis. Pyrantemide is also a cell wall inhibitor. And then for 2 months, you're supposed to give RIPE, which is rifampin, isoniazid, pyrantemide, and ethambutol. And then after 2 months, from 4 to 7 months, you're supposed to give rifampin and isoniazid. And then for multi-drug resistant tuberculosis, you're supposed to give aminoglycosides, fluoroquinolones, etc. So as we already discussed it before, this is Th1 type of immune response is interferon gamma is a cytokine responsible for stimulation of macrophages by the Th1 cells. And then why cannot we use tumor necrosis factor alpha inhibitors for tuberculosis is because this is released by the macrophages, leads to epithelioid formation of epithelial cells, granulomas, etc. And it basically helps not to spread this infection. It's helps from spreading this infection. And so if there's a decrease in tuberculosis factor alpha or inhibition, then there will be spreading or dissemination of tuberculosis. So thank you very much, and these are my sources. So